Okay, good morning, everyone. Shall we start now? Are you all settled? Okay. All right, so this is the first week and not too many people. Hopefully next week it will be more crowded, but I'm very glad to see you. So my name is Bibhas Chakraborty. I have been with NUS for more than 5 years now. Primarily based in the Duke NUS Medical School, which is in a different campus from here, but also with the Department of Statistics and Applied Probability, which is in this campus. And I'm really glad that IMS is doing more applied statistical kind of workshops these days, which is great and which embraces different disciplines. It's very interdisciplinary. So as you know, this is a mobile health thematic program, and this week we are putting together different kinds of tutorials which sort of prepare ourselves to that theme, and where we have international speakers giving cutting edge research presentations. But today my talk is more of a tutorial which it is meant to be, so sort of review of this area, and I will get to some of the relevance and application of this methodology in the mobile health context, but not from the get-go. So it will be a more general thing, but this is a related area, and this, as you will see, I mean, it will naturally move to a point where mobile health applications are relevant. Okay. I'm starting with a very non-technical description of the problem, just the bigger picture, the broader context. So we like it or not, the world is aging, and here we have shown some time series plots, the percentage of people with different age groups. You see the increasing trend of older people. And what does that mean? Is also the global shift in causes of death towards chronic non-communicable diseases. And again, the trend is very clear. The non-communication diseases increases quite a lot. And then this is a very similar trend in developing and developed countries. So normally you would think that people have the perception that non-communicable chronic type of diseases are basically a feature of the developed world, whereas in the developing world it's more about infectious and other kind of diseases. But while that is true, but irrespective of that, low income, high income, etc., everywhere the trend is clear. Non-communicable diseases are increasing. So with that context, right? So with that context, we'll talk about this chronic disease management and how to do it more personalized. So that's the broader theme, right? And what is the feature of chronic disease management is that basically you have to intervene many times, right? So that's a time varying situation. You have to treat patients again and again, collect their feedback, how they are responding to treatments, and adjust the treatment or dosage, etc., as we go along. So it's a longitudinal process, statistically speaking. So that's one feature of it. And how to make things more personalized, tailored. This is another focus area these days. A lot of people are talking about personalized medicine, precision medicine, tailored intervention, etc., etc. And that actually translates all the way to mobile-based interventions. So in that context, in that broader context, today I will review the concept of a special type of trial design called SMART design. SMART stands for Sequential Multiple Assignment Randomized Trial. And as the name suggests, it basically encompasses that picture of repeated intervention, sequential multiple assignment. You assign treatment many times, right? And then in particular, I will talk about a little bit application of smart, or the special issues that arise in the context of smart design when applied to a mobile health setting. In that context, I'll talk about non-inferiority testing and some adaptive randomization kind of concepts in SMART. Then we'll briefly touch on the estimation of optimal so-called dynamic treatment regime. Dynamic treatment regimes meaning the treatment sequences, the rules that govern how the treatment should be tailored over time according to individual characteristics, right? So how to estimate those kind of dynamic treatment regimes, and in that context, we'll review methodology from reinforcement learning in computer science. That's called Q-learning. Now, for those of you who are trained in traditional reinforcement learning, may find this version of Q-learning a bit different, because I think what we call Q-learning in our statistical literature in the dynamic treatment context is kind of different from the original version of Q-learning, which is like a lookup table based, more non-parametric thing. Whereas this one, the version I present is more parametric, similar to linear regression in a way. And in a reinforcement learning terminology, you might call it fitted Q iteration, as opposed to the traditional, or fitted value iteration, that kind of methodology, as opposed to Q-learning per se. Q-learning in the reinforcement learning literature is reserved for those more non-parametric and very infinite horizon kind of settings, which is not what we will be talking about. So just managing your expectation here, it will be slightly different from the traditional Q-learning that you might see in the reinforcement learning literature. Okay, so yeah, fitted Q iteration, and yeah, so I'll also give a simple case study example of smoking cessation study using Q-learning. I think that's the plan for today's tutorial, and we'll go slow, and the idea is that, okay, you ask questions at any point, right? All right. Okay, so as I mentioned earlier, the theme is, the motivating context is personalized medicine for chronic conditions, and this is believed by many as the future of medicine. And whenever you mention personalized or precision medicine, majority of the people think genetics, right? That's how people are thinking. But just to mention that here we will not be explicitly talking about based on genetic profiling, but many other macro level variables, like test results from diagnostic tests, of course the demographics, stuff like that. And some of these could be time varying, right? So you can still conceptualize precision medicine not at the genetic level, but at a different level, more macro level. That's what it is. But there is no harm in thinking genetics, but it's just that then the problem will become very high dimensional, and then you have to, some of the traditional methodologies may fail, and you have to adjust for that high dimensionality. So that's a different ball game, and I'm not exactly going into those details. But in principle, that can also be done. It's just that you have to, so for example, replace linear regression by something like lasso, things like that. But overall concepts should be fine. Okay. So again, going back to the context, this is a paradigm shift from one size fits all to more individualized patient-centric care. And why that is necessary? There are a variety of reasons why people may want to do that. This precision approach can address inherent heterogeneity across patients. Everyone is different. Everyone needs different kind of treatment. Then it can also address variability within patient over time. That's why this dynamic nature we are focusing on. It's not like just one time point. So it's not like you get one pill and you are cured, not like that. So you have to continuously manage your condition. That's the kind of setting we are in. And so this paradigm should be able to address that as well. And greater personalization can also increase compliance or adherence to treatment, which has been a big issue, in any clinical trial or any clinical context, basically. So by increasing compliance, you might increase the chance of success of treatment. And while personalization can incur a lot of cost upfront for some people, but overall, from the health system point of view, it should actually reduce the cost, because not everyone will need very intensive treatment. So in that bigger picture, the overarching methodological questions that we deal with are how to decide on the optimal treatment for an individual patient, and how to make these treatment decisions evidence-based or data-driven, basically data-driven. Because personalized medicine, even though this might be a trendy word in recent times, doctors, according to their own perception, discretion, they have been practicing it for a while, right? It's not like a new concept. But how do we make it data-driven? How do we pull across the combined knowledge of many physicians? That's the kind of thing that we can think about here. Yeah. No, I think here we are using those two terms as same. Yeah, because I know evidence-based medicine in some contexts, mean different things, and people think about evidence synthesis across different studies, meta-analysis, so on. But here, by evidence-based, we are translating that to data-driven as opposed to your personal belief-driven. Yeah, that's exactly what I'm saying. I said or, right? Evidence-based or data-driven. Yeah, not different concepts. But what is your background? May I know? What? Pharmaceutical. Okay. Yeah, no, that's exactly what it is. But it's just that sometimes people have specialized things in mind when people talk about evidence-based medicine, because I have heard people talking about evidence-based medicine where people necessarily talk about evidence synthesis across different studies through meta-analysis, etc., etc. Yeah. Phase 4 also. That's right. Yeah, that's right. Yeah, real world, yes. Yeah, so here I'm not going into any of those specificities, not FDA recommendation or not, this Cochrane collaboration kind of group, SCRI has that, right? So, different groups has different meaning for the word evidence-based. I'm using a very generic thing, that data-driven, whatever that means, right? As opposed to just some physician believes that something is relevant or this might work. Just as opposed to a personal belief, personal knowledge, as opposed to that, just collect data and let the data speak. That's Yeah, that's common. That's very common. That's the state of the art, right? I mean, that has been going on for a long time. I'm just saying that, this paradigm shift and the methodology that we are trying to develop is just to accumulate those data, the evidence from data. That's the goal, right? Okay. So one perspective in personalized medicine. This is not necessarily the pharma perspective, actually. This is a more societal perspective overall. So given an individual patient's characteristics, can you identify a treatment among available options that is most likely to confer the most benefit, right? So this is societal because the different treatment options could be developed by different groups, different pharmas, different companies, different mobile app manufacturers, right? So different kinds of people. So it's not like a company driven, whereas the pharma perspective would be given a particular drug, which subgroup of patients will benefit from it. So that's the target to make. Here it's different. Given an individual, among all possible treatment options, what do I give? Okay. So in that context, we define a treatment rule or regime is basically a rule or rules that specifies how to allocate treatment based on an individual patient's characteristics. And if this is administered only once, which is consistent with the acute care model of healthcare, basically single decision point, often at the time of diagnosis. You give some medicine and then you are done. So that could be the one-stage setting, whereas if it's a chronic disease, then treatments are typically administered at multiple decision points as the condition progresses. And we will be mainly focusing on that multiple time point thing, but it starts with the single time point. So I mentioned in the last slide that treatment regime, right? It's a set of rules that guides how to tailor treatment. Here, when you have a chronic disease condition, a multiple time point condition, then we call it a dynamic treatment regime, or DTR. And in fact, sometimes people prefer the word regimen as opposed to regime. So in the stat world, when it first started, it came as dynamic treatment regime. But later on, people felt that sometimes clinicians get uncomfortable with the word regime. Regimen is a more humane term, so to speak, whereas regime is a more military kind of word. So in medicine, people sometimes prefer the word regimen. So, but luckily the acronym stays the same. DTR works for both, so that's great. But different, these are exactly same thing. But if you go to the literature now, even in the stat literature, you will see both words being used. So it's basically a sequence of decision rules, one per decision point or stage, so to speak, that specify how to adapt the type, dosage, and timing of treatment according to the ongoing information on the individual patient. And I mentioned type, dosage, and timing. Not all of them may be present within a particular regime. So some regimes might be specifying just the type of treatment, A versus B versus C versus D, etc., type of treatments. Some regime might be focusing on how to tailor the particular dosage of a treatment. Sometimes it might be what dose and at what time, right? So it doesn't have to be all of them, all of those components may not be present in a particular DTR, right? But in general, it can be. Each decision rule takes a patient's treatment and covariate history as input and outputs a recommended treatment, one or more recommended treatment. And these decision points can either occur at regular intervals, like yearly follow-up visits for a chronic condition, or maybe at some clinical event, it could be a remission, relapse, complication, etc. So it actually is quite broad. The definition is quite broad, and it can cover a lot of real situations. So these DTRs offer a data-driven framework for operationalizing the adaptive clinical decision-making in a time-varying setting. So this is very common, right? So people in the chronic disease management, clinicians have all along been treating patients like that. And they collect people's feedback, how they are doing, how the things progressed, and based on that, they have been adjusting the treatment, right? So that's not new. That concept is real, and that has been practiced for a long time. It's just that we are making that process more data-driven, making more operationalized, algorithmic, so that once these regimes are developed through data, so basically you are estimating, statistically speaking, you are estimating from data certain rules, certain parameters of the rules. And once those are done, that can sit in the computer of a doctor, and whenever a patient comes to the clinic, the doctor actually collects the information, feeds into that system, and system can give recommendation as to what might be a good treatment. Or if there is no difference between multiple treatments, then also it can recommend that. So if that becomes the situation, that no treatment is effective or a variety of treatments are equally effective, then at that point the clinician can actually make it based on that. The final recommendation may be driven by cost or other considerations. Yes? Yeah. So, of course, ultimately physicians have the right to, throw this away, right? Yeah, yeah. But it's not to challenge or replace physicians, right? So, this is just to support them, So, clinical decision support systems for the doctors. Physicians, may not like it, and ultimately the decision has to be physicians, right? So, as I said, this is not to replace, it's just to help them make a better decision. When they see that, okay, this is the recommendation based on a system that actually pulls across data from, 1,000 people or, whatever from this trial, that trial, or maybe not necessarily trial, but it can also be electronic health records, it can be registry, it can be different sources of data, but whenever the doctor says that this recommendation is based on such and such studies, right? Then he or she might actually reconsider his or her earlier belief, right? That's the thing. But if that's not the case, if the physician doesn't like it, then so be it. I mean, it's not like we are seeking treatment from a system, from an AI system, right? So here, basically, ultimately we are seeking treatment from a doctor, a human doctor, till now, right? So maybe 50 years later, who knows? But as of now, ultimate responsibility of giving the treatment is still with the human physician. So it's just a recommendation, recommender system, right? So the doctor may or may not like it, may or may not implement it. It's just that we are trying to help improve the system, the recommendation. That's all. Yeah. Right. Wait. We are not talking about trial yet. Here, I'm not talking about trial yet. So I will talk about trial later. So suppose trial is already done. I'm just saying once the trial is done, when the data is ready, and then we will use some methodology, mainly driven by reinforcement learning kind of methodology. Once those analyses are done, final product of that analysis is some recommendations, right? And that recommendation, how to implement it in practice by doctors, that's the discussion we are having. We are not talking about trial design yet. I will come to trial design later. Trial design is what kind of data is good for that. I'll talk about that later. But right now, we are just giving the concept of these data-driven rules for treatment. Okay? So you already have the data. And I'll come back to how to collect that data. Okay? Yeah. Yeah. That's right. Right. That's right. Better decision, right. That's right. Yeah. Okay, great. Okay. Another thing to note here is that I'll also illustrate a bit more this point, but one thing to note here is that a subject's stage-specific treatment recommendation is not known at the start of a dynamic regime, since treatment depends on time-varying variables. So this dynamic treatment regime, these are rules, but not the treatment recommendation as such, just yet. So it just gives a rule that if certain things happen, then give treatment A, or if certain things happens in a different way, then give treatment B. But it does not tell you A or B at the very beginning. Before seeing the patient, you don't know what treatment to give. Once you see the patient, you collect their data, feed it into the system, then only you will know what is the treatment recommendation for that particular patient, right? But the system only has the parameters of those rules, so to speak. If you think parametrically, it just tells you that, okay, if your blood pressure is certain, if your blood sugar is certain, then you do this or that, right? So, but unless and until you input those blood sugar or blood pressure or other, other variables into your system, you do not know whether to give treatment A or B. Right? It's just the rule, the parameters. And I'll give you some examples about what those parameters are. So now I'm still just giving you the conceptual overview, but we'll come to specifics. Okay, so here is one example from disease called ADHD, attention deficit hyperactivity disorder, more of a pediatric kind of condition, so here we talk about the different treatment scenarios, right? So children with ADHD typically can have two different treatment options initially. Either a low intensity BMOD is behavioral modification therapy, or it can have a low intensity medicine. So one is entirely behavioral, one is drug, right? And after that, at some certain point, we are not specifying the exact time point, maybe 6 weeks, maybe a month, maybe different time points, but depending on that context, you will have an intermediate evaluation of their performance, their response to the drug or the behavioral therapy. And then you, based on some predefined measure, you assess them, you classify them as responder versus non-responder to their initial or first line treatment. Then you apply your secondary treatment, and typically if they are adjudged as responder, you might want to continue the same treatment, in this case behavioral modification therapy, and in this case the medication. Whereas if they are adjudged non-responder, you have more than one option there. What you can do is you can give a treatment augmentation, you give the behavioral modification, plus you also add the drug. And in this case, you continue the drug but also add the behavioral modification. That's one option. The other option is you intensify their first line treatment. Maybe it was a low intensity thing, maybe you give it more frequent, higher dose, etc. So these are a few scenarios where, a few alternative options for treatment. And just to show that I'm not making this up, is according to this article. Okay, so what is a dynamic treatment regime in this context, right? Here you just follow the red arrows. Together, the red arrows together constitute one dynamic treatment regime. So in plain English, it says you give low intensity BMOD initially, and then if the subject responds, then you continue that, or if the subject is a non-responder, then you prescribe BMOD plus medication, right? So this together is a rule. So remember here it basically covers the entire trajectory. It cannot be just one arm, so to speak. It cannot be just this, stop, not like that. It has to have options for responder versus non-responder, what to. So that's the complete treatment plan. But you do not know how it will pan out in the real practice, because you do not know, before the patient moves to that stage, you do not know whether the patient will be a responder or a non-responder to their initial treatment. But you have the rules. You have the rule book ready up front. You just don't know whether at the second stage you will give this treatment, whether you will continue the low intensity BMOD or you will give a treatment augmentation at the second stage. You do not know before the patient moves to that stage, right? Even if you know their baseline information, until and unless you observe their responder status, the intermediate outcome status, you do not know what their final treatment would be. So that's what I meant when I said earlier that you do not know the treatment sequences up front, but you only know the rules, you know, sort of know the parameters. And parameters are specified here in this case by the, say, threshold of that some kind of a continuous score maybe, and based on that you tell them, you call them responder versus non-responder, right? So that's what I mean. Okay, So I give two different examples of DTRs here. The stage 1 rule, it could be, so earlier one was very, very straightforward. It's just according to those arrows, right? We are just adding a little bit more complexity here. So if the baseline level of impairment is greater than a threshold, prescribe medication, otherwise prescribe BMOD. And the stage 2 rule is the subject is a responder to initial treatment, continue the same treatment. If non-responder, prescribe the augmentation, right? So stage 2 is same as before, but stage 1, earlier it was just, give low intensity BMOD to everyone. That's sort of the rule. But here you are incorporating baseline information that if the baseline level of the disease is above a certain threshold psi, then only you prescribe behavioral modification. So that psi becomes a parameter of the rule, right? Just like the responder, non-responder cutoff can be a parameter of the rule, but in this case, even at the baseline level, you can incorporate a parameter. And I'm just making things simple, but you can have a linear combination of a different set of pre-treatment variables, or a nonlinear combination for that matter, right? So any kind of, you can think of a complicated function of different variables at the baseline, and based on that you can give one treatment versus other. Of course, we don't want to make it too complicated because that would often turn off the physicians, but in principle, when we are talking mathematically, that is possible, right? So that's how different kind of parameters can be incorporated in the decision rule. Okay? Yeah. Yes, yes. No, not necessarily, not necessarily. Not necessarily. So these rules can come out as secondary analysis of the trial data. So when you design the trial, you don't have to go through, because that's unrealistic, as you are probably thinking that you cannot have designed so many rules and implement that in the trial. No. So the trial will be more straightforward with a very crude level of personalization, so to speak. Not in that fine granular level, but you get this kind of granularity by doing secondary analysis of the trial data. Some may be pre-designed, but then you can also do sort of regression type analysis, just like you do subgroup analysis in a traditional trial, right? So here also, when I talk about SMART, you will realize that when you're designing the trial, SMART is in a way pretty crude. But then when you do this analysis of the SMART data, then you can do all kinds of regression type analysis, which in this case is Q-learning. You can do all those things and experiment on those parameters, and you can basically estimate the optimal values of those parameters, those psi kind of parameters. Those will be estimated from the analysis of the data. So there are two different things here. One is designing the trial, one is analysis of the data from that trial. And the recommendation is that because of all kinds of practicalities, you cannot possibly test out everything in your trial design, so to speak. It cannot be designed that way. But you keep the option open to do the analysis of that data and estimate a variety of parameters from there. And that's how this will come. Yeah. Yes, that's normal. That's right. Yeah. Right. Sure. Right. Right. Okay. So forget about all this thing, but just think of a two-group RCT, right? Two-group randomized trial. So, well, as the name suggests, it's only A versus B, you randomize people, but then you are not implementing any rule, right? Okay, but you still collect a lot of baseline information, right? But then once you have your trial complete, your primary analysis is A versus B, right? Primary analysis done, primary analysis paper published, done. But you can always do a lot of subgroup analysis. And so, for example, you can do a regression, right? You have your Y, the final outcome on, you regress it on the treatment A or B, and then all kinds of your baseline covariates. You put it in, and you also study the interaction between covariates and your treatment recommendation, right? And these interaction parameters are very important in that regression equation, right? So all the interaction terms, they are very important in personalization. Based on the estimated values of those interaction terms, you might recommend that, okay, this treatment A is better for people with such and such covariates, right? That is something very commonly done, right? Here, in that case, and based on that, you can recommend a treatment, right? You can design a data-driven rule, so to speak. That's based on that regression analysis, which is sort of a secondary analysis of the trial data. So here, we are just talking about an extension of that idea to a multi-stage setting. Right? So we call these kind of designs, I'll come to the design specifically, but whenever you have multiple randomization, you give something to the people, and then based on their response, non-response status, you give something else, and you might continue this for a few steps, right? Not just two, but potentially a few more. And if you don't have any problem on the resources, then you can, in principle, you can do it as many times as you want. So then you have to incorporate all the baseline as well as time-varying covariates on the patients, and then throw them in your appropriate models. And it could be regression, like the traditional regression models, or it could be, so everything will be done in a reinforcement learning setting. But even within reinforcement learning, at each stage, it's a stage-wise model, right? So within reinforcement learning, at each stage, you may consider like a standard linear regression sort of idea, or you can do a more sophisticated machine learning type of ideas, supervised learning kind of ideas, like support vector machine or neural nets or whatever. You can do all kinds of things there. But the ultimate goal of all that exercise would be to basically find subgroups of people where certain treatment is better, right? So that's all I'm talking about. So trial design is one thing, and the secondary analysis of data, and you can get as sophisticated as you want, and then you can estimate those parameters of the rules, these psi type of parameters. Okay, and I'm sure there is still some confusion, but as we go, you will see the distinction I will make, and I'll give clear examples of how you do estimation. Okay. Okay, I think this is another point I mentioned earlier about treatment regime versus the realized treatment experience of an individual. So we continue with the same example. See, you follow the red arrows, but you see there are two different pathways, the upper one and the lower one. So subject 1 experiences this B mod followed by a response outcome, and then followed by the same treatment continued, right? So this is one pathway, one realized experience of that same regime. Whereas this one, the lower path, is what a different subject experience, low intensity B mod followed by a non-response as intermediate outcome, followed by treatment augmentation, giving both treatments. So see, the two individuals are experiencing different treatments, but they are both consistent with the same rule. That's one important thing to notice. And so when we try to estimate, what is the implication of that? The statistical implication of that is that when we are trying to estimate the effect of that rule, effect of that regime, then we have to combine data across these two different kinds of people, right? even though their treatment experiences are different. And in fact, we will see, they might need to be re-weighted, not just everyone just added up. There needs to be a weighting process, because here everyone who responds gets there, but here non-responders might have different options. So okay, we'll come back to that point later, but the point here to keep in mind is that you have to combine across different kinds of treatment pathways to estimate the effect of a rule. It's not just one arm of a typical randomized trial. You might have to combine across different sort of arms, sort of experiences of the people. Okay. I think now it's time, after the intro, basically to give you a bit more notation so that you know exactly what is being meant here. Okay, so it's a slightly bit more than standard longitudinal data. And what do I mean by that? In the standard longitudinal data analysis that we traditionally are trained in statistics is that we observe the outcome many times, but not the treatment. Treatment is typically, even if you are collecting longitudinal data from a trial, treatment is given, like A or B sort of thing. Treatment is not A followed by B followed by C, etc. No. So it's just treatment, but it can be a treatment plan. It can have it a priori fixed, but it's not outcome-driven change in treatment. It's just treatment A versus treatment B. And then you observe the outcome, say, weekly, right, for a few time points. So that's typical longitudinal data that we observe and analyze. Here it's a bit more than that. Here it's intertwined. The treatment and outcome, they're intertwined. So here we are using notations O and A. O is the observation. It can be, it is basically the pre-treatment observation at the jth stage, that's OJ. And then AJ is the treatment and action at the jth stage. And so AA is basically coming from that word action as opposed to treatment, because there are so many T's, so we don't want to use the thing T, because T is also time. So OJ, AJ, and so this AJ can come from a small finite set, script AJ. It can be binary treatment, 1, 0, 1, minus 1, the way you want to code it. And then history, HJ, we define it as the combination, as the collection of all observations up to the current time point. Say HJ captures all the O's up to the jth time point, OJ. And it also captures all the treatments up to the j minus 1th time point, not the jth time point. It's pre-treatment at stage j. So everything that happened before the jth stage treatment, right? That's the collection of history. And Y is the primary outcome. That's what we will consider, and we will assume that larger is better. And this is without loss of generality, because if you have an outcome that you want to minimize, you can always work with minus Y, or you can work with a large constant minus Y, right? So then things are fine. So without loss of generality, we might assume that we want to maximize the outcome, the reward. In reinforcement learning, people call it reward. So with that notation, a dynamic treatment regime that I have been speaking about in words, mathematically means this is a sequence of decision rules D as a collection of D1 through Dk, depending on how many stages you have. If you have k stage, then this is the notation, D1 through Dk. Each one is a rule. Each one is a mapping from the space of history to the space of treatments or actions. So you have Dj of Hj. So you observe the Hj of the patient. You input into that system, into that Dj, the rule, and that will spit out a treatment recommendation that falls in that Aj, the given treatment space, right? That's mathematically, that's what it means. And you might wonder why we are working with H as opposed to O, right? So it basically, that's how it's done. If you think clinically, doctor always looks at the medical history, right? Everything that has happened before. And you might want to work with some summary of that. it may be, if it's a long horizon from if K is large, right? If the number of decision points is large, so then H increases very fast, right? You have a lot of data being collected, so you cannot incorporate everything in your decision rule. Or if you think like a linear combination or something like that, then there might be too many terms, right? So you might work with some low-dimensional summary of that, summary statistic of all that data. Or you might do variable selection. You might have a few variables in that decision rules. So these are other considerations to make. But in general, everything can fit into that decision rule. Okay. And another thing to note is that in the traditional reinforcement learning, people often work with Markov decision processes. So basically, you observe the state and then you can forget about the history before, right? Here, if you want to apply that kind of scenario, then you have to first capture the history in your state. So this history can be your state, or a summary of that history, relevant summary of that history can be your state, and so that you can forget about the past. So that way, by cleverly formulating your history variable here, you can make it a Markovian situation. Even though in real clinical practice, things are typically not Markovian, right? You have to think about the entire history. Okay. Yeah. Right. Right. And so basically, if you directly want to apply methodologies from that Markov decision structure, then you have to first create your state in a way that captures the entire history, right? May not be all of that. And once you create that history, that state variable, then no need to basically think about the entire history. That's the point I'm trying to make. Yeah, right. Right, sure, yeah. Right. Okay, yeah, so Y can be like an end of trial, end of the study outcome, but it can also be added outcome. So meaning, every time point, whatever you are getting, this might add up, or some function of that, right? Yeah. Right. Finite situation. This is all finite, right? Yeah. Right. Yeah, right. So it's not exactly the classical MDP settings. I would not say not precise, but it's also the MDPs are not also mostly for infinite horizon, right? Yeah, so here typically we are talking, and particularly when observational data, I think here also you can think like infinite horizon, but when we are talking about trial, then it's only a very few finite steps, right? So there are quite a bit distinctions, and I think, Jesse, will you talk about anything later about MDPs? Yeah, okay, so Jesse will be talking about MDP kind of learning in this context in the last week. Yeah. All right. So we have all kinds of people here who will talk about different things, but I'm just talking about what the, in the dynamic treatment literature, what we did early on. Okay, all right. Okay, so the big questions in the DTR research is what would be the mean outcome if the population were to follow a particular preconceived DTR, right? And we're talking about mean because, okay, we first think about continuous outcome. I mean, other outcomes you can also deal with in different ways. You can work with a quantile of the outcome, or you can binarize things and so on. But first thing is continuous outcome, the simplest setting, and you think about the mean outcome of the population if the population were to follow a particular regime, particular DTR. And as I said, it's not exactly same thing as following one treatment arm. It's not following A. It's following A and continuing A if responder, or switching to B if non-responder, etc. So it's a rule, complicated thing. What would be the outcome corresponding to that rule, following that rule? And then the natural extension is that what would be the mean outcome? How do the mean outcomes compare across two or more regimes, right? So it's an extension of that same idea. You have one rule, another rule, and then how you compare. And then the final thing, which is probably the most important, but that's typically not the primary goal in a trial setting. It's essentially the secondary analysis type of data. What is the optimal DTR in terms of the mean outcome? And when we talk about optimality, the natural question is what individual information, which can be called tailoring variables or prescriptive variables, do we use to make those decisions? So that's basically a variable selection kind of question. So in that DJ I mentioned, right? So if there are a lot of components of that history, what summaries do we use in there to make the recommendations? Okay, and so those were the more scientific question, but now specifically statistical questions here. What is the right kind of data for comparing two or more DTRs or estimating the optimal DTRs? What is the appropriate study design, right? So that's where the sequential multiple assignment randomized trial, or SMART, comes into picture. Then how can we compare preconceived? Embedded DTR is another terminology that is used. So these rules that are already embedded within the trial, you can easily extract that, as opposed to extracting rules by incorporating artificial psi kind of parameters, the threshold kind of parameters, right? So without doing that, just the ones that are embedded, like responder, non-responder, etc. By trial design, the things that are already there, how do we compare them, right? So that can be a primary analysis of a SMART data, just like we do A versus B comparison in a standard RCT. And then the final question is how do we estimate the optimal DTR for a given patient? And that basically, as I've been mentioning from the beginning, that falls under the secondary analysis of a SMART data. And typically we can use this Q-learning, a stage-wise regression-based approach that was originally developed in the reinforcement learning literature in a slightly different context. And in fact, as I mentioned earlier, the Q-learning that as we describe it here is more like the fitted Q iteration in classical reinforcement learning, as opposed to what is called Q-learning there. But this Q-learning basically follows one of Susan Murphy's early papers that was published in a high impact machine learning, Journal of Machine Learning Research. That's where she first extended the classical Q-learning idea to fit into this medical paradigm. But that was published in a computer science journal. And basically we'll be following that. But later on, I realized that reading some other literature from the computer science, I realized that the fitted Q iteration fits better for what we call Q-learning. Okay. All right. We already reached the break time. Maybe we continue for another 5-10 minutes and then take a break, yeah? All right. Okay, SMART design. Okay, so now we are talking about discovery of DTR. How do we find out, what could be a good DTR and so on? Of course, the natural choice is observational data because there are so many, right? And data collection is very cheap. And this observational data, of course, includes electronic health records, which is huge resource these days. But the one problem, and these are well documented in the literature, one problem with observational data is that confounding and other hidden biases there. And basically, you do not know all the reasons why they got certain treatments. There may not be data collected on certain variables that clinicians use to give the treatments, right? So that problem is there, and to make causal inference out of that data requires a lot of unverifiable assumptions. So that becomes a problem. But still, there are a lot of methods in causal inference you can use nonetheless to make the best out of that data. But basically, the data source is not the ideal, right? Even though that's in plenty. And specifically in the dynamic treatment regime context, also we have done some work with observational data, and we have found that is generally more complex compared to randomized data. So that's the general understanding. So of course, experimental data, if you can afford it, that's the best option to proceed. But the standard RCTs assess the effectiveness of a single dose level of a single treatment as compared to another. That's the classical paradigm. And even if you have sort of like a stepped care setting, if you have a sequence of treatments, but that has to be prefixed, predetermined, and then you can compare with a control, etc. But you cannot make your treatments, treatment recommendations outcome driven based on responder, non-responder kind of status. You cannot make it in a standard RCT. So that's why we have to think outside that classical paradigm. So estimating the sequence of treatment that optimizes response in a longitudinal setting, it requires studying the elements in a sequence. But the question then comes whether this can be done through a series of single stage RCTs, something that we already know, everyone knows, without going into any more sophisticated trial structure. So we give an example to see whether you can stitch together treatment recommendations from different RCTs and find whether that gives you what you want, right? Okay, so we consider treatment of major depressive disorder, MDD, and we wish to compare both the frontline and second-line treatment options for that depressive disorder. Frontline options are citalopram, a drug, or cognitive behavioral therapy. And then second-line options are treatment switch to either citalopram or CBT or lithium. So people who get citalopram at the front line may be switched to either CBT or lithium, whereas people who got CBT early on, they might switch to citalopram or lithium, etc. And all responders to first-line therapy will continue with maintenance and follow-up. So the goal is to find the optimal treatment sequence as opposed to optimal treatment in stage 1 and optimal treatment at stage 2. We have to always think like a sequence, think in terms of a sequence. Okay, so this is the sort of the structure where we can do. So initially citalopram and CBT, these are the two options, and then later on you might consider a treatment switch, whereas responders can continue. So these are the basically three. If you think like a randomized trial, these are the possible 3 randomization nodes where you can compare. Okay, frontline treatment, right? So this is the first randomized trial. You can think, forget about SMART, DTR, etc. Just a standard RCT. And suppose you observe 60% response with citalopram and only 50% response with CBT. So, and this response is basically your final outcome. It's a binary outcome you are thinking now. And you can conclude that citalopram is the best frontline therapy because based on that 60 versus 50 data. We're not getting into statistical significance, etc. Suppose this is statistical significance, right? So just okay. So now, so this you have in a way by taking this approach, you have settled this first question that first line citalopram is best, right? So we don't have to worry about CBT anymore. So now another one-stage trial amongst citalopram non-responders because, okay, if you go back, so you have settled this question and this approach says that since citalopram is the best first-line treatment, you just do another comparison of what to follow that with and you do not worry about this part anymore because CBT is not so good initially, okay? Okay, so that's the second line treatment for MDD among the citalopram non-responders. Yes? No psi. Yeah, I'm trying to keep things simple. No psi yet. That will come later. Yeah, just randomize. Just RCT type of idea. We're now talking about RCT of a first stage, and then RCT of a second stage, right? So here we know that 60% response that we observed already saw in the previous slide. Now suppose we observe 40% response to CBT and 20% to lithium among the non-responders of citalopram, right? Okay, so here from that data we conclude that CBT is the best second line therapy, right? That's trial data. And then the final treatment sequence based on this approach, we are considering an approach where we are stitching together evidence from two different trials, right? Two different single stage trials. So the final recommendation for the sequence then becomes you give citalopram followed by CBT for non-responders, right? And under this regimen, this becomes a rule, right? Becomes a regimen. And we expect to see an overall 76% of patients respond because first stage we know 60% response, and then so there is remaining 40% here, and out of that 40% respond to CBT. So 40% of 40%, that is 16%. So together it's 76% patient respond overall in this regime, right? So that's the optimal treatment recommendation by taking this approach, which basically is synthesis of data from two different trials, which are staggered, which are at different stages. Right? This is not the smart design approach, not to confuse with that. So we'll come to that later. We'll contrast this approach with the smart approach. But this is what you, without knowing about smart or DTR or reinforcement learning, any of these ideas, if you want to go with your usual knowledge of trials, this is what you would do. Now we'll see what happens. Okay, so there can be this phenomenon called delayed effect, and you can play around with these numbers and see, in many situations this delayed effect might play a role, and that might lead you to a different optimal sequence. So what if the initial treatment, so conceptually, scientifically thinking, what if the initial treatment with CBT increases your treatment adherence, right? That can happen because it's a cognitive behavior, it changes your behavior. Ideally, it should change your behavior, right? So that might help improve your adherence to treatment, and which means that subsequent treatments might be more effective, right? So that's a delayed effect of your CBT upfront. If that's the case, and if the numbers are actually like that, so 60%, 50% here, 40, 20, and then here, see, because of the delayed effect in a way, you get 60% and 30% response, as opposed to here, there is no delayed effect playing. It's just a drug, right? So you switch to something else. But here, CBT trained you better to have greater adherence, because of which you adhered to your second line treatments better, so you get better treatment success here. If that's the case, and if you take this pathway, so CBT here, followed by citalopram for non-responders, you'll see overall 80% response. So 60% of the remaining 50%, so that's 30%, added up to the 50% here. So overall, this regime would give you 80%, right? So this is something that you would miss if you just synthesize data from 2 different trials at different stages, which we did earlier, right? Because this setting did not think about the delayed effect aspect. Yeah. Yeah, I think so, yeah. Yeah, I'm not going, as I said, when I talked about this earlier approach of synthesizing just 2 RCTs, I'm not talking about any of this dynamic thinking. I'm just motivating the dynamic thinking, the sequential thinking, right? Yeah, of course, MDP can handle that, but that's a sequential thinking, that's a dynamic thinking, right? Okay. So basically the bottom line, the message from this numerical exercise is that 2 single-stage trials would not have detected the best overall strategy for treatment. Instead, we should have considered 2-stage trial. And this kind of 2-stage trial where you randomize and re-randomize in this setting, that is known as the SMART design. And it came into practice from the early 2000s. I think there might be something even earlier at MD Anderson Cancer Center. They also have something similar. But I think with this Lavorian-Dawson article and then the Murphy 2005 article, these concepts were formalized. And as you know, Murphy will be here as a distinguished speaker for the next couple of weeks. But she will not talk about these things. She will talk about this mobile health specific other trial designs. But this is also, the SMART is also her earlier work. Okay, so this is Susan Murphy, and she actually got this MacArthur Foundation Genius Grant in 2013, specifically for inventing the SMART design concept. And you can follow that link to see more details about it. And MacArthur Foundation, I think for those of you who are from the US know that this is a big deal in the US because it recognizes people of extraordinary abilities in, from any discipline. And not just science, it's even like arts, music, whatever, right? So it's basically exceptional people in it. So this is a very rare accomplishment by a statistician for doing this kind of for basically formalizing the concept of such a trial design that can be widely applicable in medicine and health in general. Okay, so I think I should stop now, take a break, and then so maybe 10:35 we come back. Okay, all right.